This is an interesting case of Bertolotti syndrome where practically the lateral mass of the L5 and S1 almost grow together but not quite. That create a mass that with motion it just hits the bone and can be very painful. Here you see partially faceted or trying to grow together. Here you see it in the coronal and axial view. If you look carefully, you see that the contralateral facet is growing tremendously, diseased together, and it's because it's hitting here and put lots of pressure on the contralateral facet. So it's not by chance that the contralateral facet in partial Bertolotti is more diseased. As you see here, we call it hugging facet because one facet grows around the other one. That can be obviously very painful. And this patient had failed conservative management and has symptom corresponding. As you see, facets are really horrible in 455 S1. Underwent this surgery today for L455 S1 OLLIF transcameral OLLIF fusion. Here, the surgery. We start the surgery around 9:10. First, we put facet in. I want to see that first of all, when we started the surgery, there is this here. Here you see on the left, and I'm sorry, on the right side, you see the Bertolotti that almost sacralized S1, but this is not it. That partial growth is up here. This is actually, you can see it in the CT. When we go down, there's significant sacroiliac joint disease and osteophytic changes in the significant osteophytic changes, as you see here and here, just at the disc level, that with the Bertolotti syndrome and the facet disease, it superimposes everything here. It gives us not a clean shot, but I'm still able to see the discs. So in the surgery, first we tried to do OLLIF for L5 S1, but because of all this growth, we couldn't get an approach. So I decided to do our new method of this surgery, which is called transverse OLLIF. Here you see that after I go with the neural monitoring, I put it in the right trajectory to the disc. That's all what it is, the right trajectory to the disc. Here you see my attempt there, but then after I tap that K-wire a few millimeters into the bone, I dilate first, and then over dilator, a cannula goes in. The cannula cores into the bone, and then over that I start with drilling. The next few minutes is spent by drilling and advancing the tube little by little. We stimulate this tube with 10 milliamps. So if you are close to any nerves, you would know nerves can give you a signal as low as 2 or 3 milliamp. So by stimulating it at 10 milliamp, we get a good understanding that we are not close. Once, as you see here, we drill, we go slowly down and drill and advance the tube. Then we put a K-wire inside of the disc base, and over the K-wire we are able to advance a dilator. Then the tube or working cannula get entered, and then we perform a discectomy. Here you see the discectomy, and then we cut quite large cage. Especially about this approach is that we have a small opening, 1 centimeter, but this cage is 14 millimeter cage. So I put the cage not in the direction that it's going to be finally, and the top and bottom hitting the end plates here and here, but 90-degree turn in the lower profile. So practically I'm going to break the bone laterally. I don't want to break the bone superiorly toward the nerve root. And then once in place, here you see that I turn the cage in the proper position, and you see it opening up the space, and here you see that again. The cage is placed this way, and then it's turned to final position. And here you see actually the path. Then put K-wires in the S1, and then I do the regular OLLIF in the 4-5, and then after proper positioning of the cage, we finish the job by putting K-wires in the 4. Here you see that again. All the K-wires are placed now in all 3 levels, and here we dilate, decorticate, do a posterolateral fusion, and then put the screws in, and then pass the rod. And here you see the final pictures. Patient woke up, leg pain is gone, patient is doing very well, and most likely will go home tomorrow, which is less than 24 hours after the surgery.